The SRF was founded in the late 1980s by patient activist Sharon Monsky. Today, the SRF is the nation's largest nonprofit funder of scleroderma research. The mission of the foundation is to fund, facilitate, and bring forward basic, translational, and clinical research, and ultimately, if you will, to find a cure for scleroderma. The SRF is singularly focused on this mission and spends over 80% of its entire budget on these activities. Before we get into today's proceedings, I want to spend a minute and talk about Bob Saget. There was no one more invested in the mission of the SRF than my dear friend and our dear friend, fellow board member, Bob Saget. Bob was an unfailingly generous person and a relentless crusader and champion to find a cure for scleroderma. He'll be deeply missed by many, but particularly by us at the Scleroderma Research Foundation. Bob worked side by side with us for over 20 years as a board member and longer than that as a contributor to do everything he could to aggressively push forward a mission to find a cure for scleroderma. But with that said, let's turn to today's webinar. It is my distinct pleasure to be able to introduce to you Dr. Zsuzsanna McMahan. Dr. McMahan is the Associate Professor of Medicine in the Division of Rheumatology at Johns Hopkins University. She completed her medical school and residency training at the University of Texas and her fellowship training in rheumatology at Johns Hopkins, where she also earned her master's in health sciences in clinical investigation. Upon completing her rheumatology fellowship, Dr. McMahan joined the Johns Hopkins Scleroderma Center as full-time faculty back in 2012. And she's been an integral member of the team since then. She's focused her time on clinical and translational research, particularly relating to gastrointestinal complications and for caring for patients with those symptoms. Her research is currently funded by the NIH, and she has a long history as a funded researcher of the Scleroderma Research Foundation. She co-leads the International Scleroderma Clinical Trials Consortium on Gastrointestinal Working Group with Dr. Elizabeth Volkman, and she's integrally involved in the leadership of the ACR, the American College of Rheumatology, where she's currently clinical chair of the International Annual Scientific Meeting. Very pleased to welcome Zsuzsanna to our webinar today and to speak about gastrointestinal involvement in systemic sclerosis. Zsuzsanna?
Thank you very much, Luke. Let me share my screen. I appreciate the introduction. Okay.
And I think you just need to go to presentation mode.
Yep. There we go. All set?
Great.
Okay. So thank you again, Luke, for the introduction. It's a great honor to be here to speak on behalf of the SRF and on the research that we have accomplished in the last several years to translate to patients kind of the importance of what they're going through to us as physicians and us as the SRF. And this is a topic that's dear to my heart. I will be speaking to you for the next 25 minutes or so on scleroderma and gastrointestinal disease. And it's something that I'm really passionate about, really because of a couple of patients that I had interacted with early in my career. And I wanted to be able to help more than we were able to at that time. And so that's why I focused my career on trying to understand this better and take care of patients with this particular complication of scleroderma. And so while the next 25 minutes will not be comprehensive by any means, I'm always available to speak further and answer any questions that may arise in the coming slides. So on that note, I have no relevant disclosures, and I will reference the off-label uses of drugs. So for the next 25 to 30 minutes, we will discuss the manifestations of systemic sclerosis related gastrointestinal disease, review some of the mechanisms of normal GI motility so that we can understand scleroderma GI dysmotility. We will go over the approach to the way that I diagnose and manage patients, and then I'll provide a very brief overview of some of our ongoing research studies. So first, we'll go into an overview of the gastrointestinal subsets that are involved in scleroderma and the way that scleroderma often presents in the patient's life. So there are many different symptoms that are associated with gastrointestinal complications of scleroderma, and the experience of patients may vary widely. So anywhere from the oropharynx, where you can see at the top left, the photograph of a very dry, parched mouth, to a small oral aperture where you see the narrowing of the oral aperture, where it can be challenging to bite into a large sandwich, for example, trouble with swallowing, burning in the throat from chronic acid reflux, narrowing of the esophagus, which you can see here, where you have some scar tissue after chronic exposure to acid reflux and scarring. Slow emptying of the stomach can occur, which can lead to nausea and vomiting. Dilation and slowing of the bowels, which you can see on this radiograph. And you can also experience symptoms of fecal incontinence, which can be particularly challenging as well. So it's important to know that while a variety of symptoms can affect patients, that not every patient is affected equally. So any part of the gut may be involved in patients with systemic sclerosis or scleroderma, which I will use both terms throughout my presentation, so just be aware of that. But the esophagus is by far the most common. So about 90% of our patients are affected by esophageal involvement and esophageal symptoms. Other areas of the gut, however, may also be involved, and those can include the stomach, the small bowel, which those two are a little bit less common and affect about 30 to 50% of patients, and then the large bowel and the anorectum, which are a little bit more common and affect at least 50 to 70% of patients. Now, it's also important to realize that while the distribution of the regions of involvement in the gut may differ across patients, the timing of the onset of gastrointestinal symptoms may also differ across patients. Some patients will have involvement of the entire gut within the first couple of years of their disease, whereas others may only have esophageal reflux throughout their entire disease course. And still others may begin with esophageal reflux and end with involvement in the colon, for example. And so there's a lot of variability, and that can make it challenging for us as doctors to communicate to patients exactly what they're going to experience during their time with scleroderma. And so that's one of the areas of research that we're trying to focus on, so that we can provide you with a little bit better of an understanding of what you'll potentially be dealing with in your during your time under our care as doctors. So now that we kind of have a sense as to what scleroderma GI complications can look like clinically, what are some of the causes of GI dysfunction in scleroderma? So I like to think of the normal gastrointestinal tract like a tube of toothpaste. And the reason I think that's helpful for us to understand is that when we apply pressure, when we squeeze the toothpaste with the muscles in our hands, the toothpaste comes out. And it's very similar to the way that food is transferred throughout the intestines in your body. So bolus of food is ingested, and you can see on the slide, it's the little green ball, into the inside of the tube, which is your gastrointestinal tract, starting in the esophagus. And muscles, just like your hands around the toothpaste, squeeze that bolus of food forward so that the bolus is propelled throughout the gut. And this motion is controlled by 2 layers of muscle that line the gut. One is called the circular muscle layer, and the other is called the longitudinal muscle layer, and they work together to make this happen. Now, it's important to understand that the muscles aren't the only players that are really important in normal gastrointestinal function, but the nerves also play a significant role. So you have nerves that extend from the brain and innervate the outside of the gastrointestinal tract to drive normal transit of food. And you also have nerves within the walls of the gut that are really important in helping the food move forward. So as you can see, it's complicated, and dysfunction of either set of nerves or the muscles within the gut can cause problems and symptoms in patients. So in scleroderma, we've come to realize that one of the major problems that we see is related to the smooth muscles in the walls of the gut. And so the smooth muscle atrophy is something that's prominent in the GI tract when we look at it under the microscope. And I think we all have a good idea as to what normal skeletal muscle looks like in the human. So this would be the muscle mass of someone who's, let's say, 20 years old. And as they age, their muscles tend to become a little bit weaker unless really major work is done to maintain the muscle mass with exercise and weight training, etc. And the same thing can happen to the gastrointestinal muscle in the GI tract that surrounds the GI tract and propels food forward. And you can get atrophy, not in the context of aging per se, but in the context of scleroderma. And so that atrophy leads to weakness and again interferes with the normal ability to move forward efficiently through the gut. So that creates problems for patients because the slow movement of food throughout the gut leads to backups. And in that context, symptoms such as reflux, nausea, vomiting, constipation can all occur and really interfere with somebody's quality of life. And so this is an example of how I just showed you what can happen with smooth muscles. And this is one of the examples of how nerves interacting with muscles can cause dysfunction in a different way in the scleroderma gut. So I want to share with you data from what's called an anorectal manometry study. And this study is often performed in patients who have significant constipation or patients with significant fecal incontinence. And in this study, you can see in the picture here that the strength, which is measured by the red and the orange colors, the strength of the muscle contraction is supposed to be high and sustained because these are muscles that help you to control your bowels and help keep stool inside until you're ready to release it. And this is what you're supposed to be able to do when your nerves and muscles work together so that when you're in a social setting, you don't accidentally have a bowel movement. Now, in patients with scleroderma that have this problem, this is what their anorectal manometry testing can look like. Instead of having that nice red-orange pressure sustained throughout the time that the pressure is measured, there is a lot of weakness that you can see. It's in the light blue and the dark blue that shows that they're unable to maintain the pressure required to keep their bowels controlled. And so that's one example of the nerves and muscles interacting poorly and causing clinical problems in this disease. So now that we understand some of the reasons why patients might experience some of the symptoms that they have, it's important to think about the anatomy in the body and when we're trying to develop a plan for treatment. And so there are various areas of the upper gut that you can see listed here in the diagram that can be involved in scleroderma. You see the esophagus, the stomach, and then this inferior esophageal sphincter. And that sphincter acts as a valve between the stomach and the esophagus to try to keep acid in the stomach. And so the esophagus does not have the special lining that protects it from acid. The stomach has a protective lining that protects it from acid because it needs acid in there to help digest food. So when this valve that's supposed to separate the esophagus and stomach doesn't work very well, it can cause problems with making acid reflux a major problem. So that can lead to regurgitation of food. It can lead to worsening symptoms of reflux. And over time, if you have acid exposure in the esophagus, you can get a lot of scar tissue, and that can lead to blockages and trouble with getting food through the system. So if the esophagus itself is affected, the muscles, as we talked about earlier, can be weak. So you can get slow transit of food and the sensation of food getting stuck. And if the stomach is involved, you can have slow emptying of the stomach, decreased ability of the stomach to accommodate food, and lead to many of the symptoms that you see listed on the slide. So it's important to understand, especially in patients with more refractory symptoms that aren't treated easily by standard lifestyle measures and basic therapies that are low risk. It's important to understand what's causing the severity of the symptoms that they're experiencing. So oftentimes we will use different tests to measure function in each of these areas of the upper gut. So there is a test called the high resolution esophageal manometry, and this test is able to measure the strength of the that lower esophageal sphincter, that valve that's supposed to separate and keep acid out of the esophagus. There's also pH testing that can measure the amount of acid that's breaking through medications that the patient is taking. There is the upper endoscopy, which is a really important test that most people will have to get if their symptoms persist despite minimal or basic interventions for reflux. This test is helpful to look at the structure of the esophagus, make sure there aren't any blockages or inflammation in the esophagus itself that would be interfering with the patient's ability to respond to treatment. And again, the high resolution manometry can not only assess that lower esophageal sphincter, but it can also assess the strength of the muscle contractions pushing food through the esophagus. And then finally in the stomach, we have a gastric emptying study, and this study is helpful in looking at how efficiently the stomach is able to clear both solids and liquids that are ingested. So the treatment of upper GI disease and scleroderma, you can see, is complicated and requires a good assessment of the whole clinical picture if patients have more refractory symptoms. But many of our patients don't, at least initially, have really severe symptoms, and they can at first benefit from lifestyle modifications. And so some of those modifications that we recommend to minimize symptoms of acid reflux include sleeping on the left side of the body, raising the head of the bed so that gravity can help keep food in the stomach, avoiding eating 4 hours before bed, just because it helps to get food out of the stomach so that it's not refluxing back into the esophagus when you're sleeping. Eating smaller meals, avoiding acidic foods like you see in the picture. The tomato sauce can be a killer in many of these patients in terms of aggravating symptoms. And then avoiding things like smoking and alcohol can also help reduce symptoms of acid reflux. So those are the things we typically recommend first line. And at this stage, we don't typically recommend testing, or at least objective testing like we discussed before. Then if symptoms continue despite lifestyle modification, we may add medicines that block acid like PPIs or proton pump inhibitors and H2 blockers, which I'm sure that you have heard of or encountered in your walk with acid reflux. And then there's a new group of medications coming out that may benefit patients with scleroderma who have acid reflux called potassium competitive acid blockers, and they're faster acting and people can really benefit from a better response to treatment with GERD. And they're still not approved here in the United States yet, but they've been studied in Japan, and the results are promising. So then if the symptoms continue and higher doses of acid reflux medicines are needed, that's when you might get additional testing like we talked about before, and need a medicine to help strengthen the muscle contractions in the esophagus to get that food through the gut, at least the upper gut. And so that's where we would consider medicines like Reglan and Motegrity and Motilium to help strengthen the muscle contractions. Then if the valve, the lower esophageal sphincter, is weak, there are certain medicines that have been shown to help strengthen that valve. And then if the stomach is slow to empty, there are many medications that can help strengthen those muscle contractions, many of which overlap with the medicines that are used in the esophagus. And so sometimes we need to use combination therapies, as you can imagine, with acid reflux, helping motility, and or helping strengthen the lower esophageal sphincter to really come up with a good treatment plan for a more complicated patient with more severe disease. Now, so here's an example of a case. I always like to bring it back home so we can think about how the things that we've learned might impact the way that we approach somebody with more severe disease. So this is somebody who's 35 years old. They have scleroderma and present with significant acid reflux. They've tried the lifestyle modifications and the H2 blocker medicines that we talked about, but they still continue to have symptoms. We subsequently added a daily proton pump inhibitor, but their symptoms continued. And so the question is, what is the next step for this patient? So I know this is a busy chart, but I like to use this algorithm as a sort of guide to help manage patients with upper GI disease. You can see that this patient had sort of empiric treatment, meaning treatment of the acid reflux alone without additional objective testing to see what was going on. And despite the interventions, the lifestyle modification, the therapies, they still had continued acid reflux. So in this situation, you'd increase the proton pump inhibitors to better manage symptoms. But if symptoms continued in this situation, you'd start to worry about what else could be going on. You'd want to rule out and make sure there's nothing in the esophagus itself that's abnormal and keeping things abnormal from a structural standpoint, meaning a blockage like a stricture or scar tissue that we talked about earlier, a mass or something like that, and maybe an infection that's irritating the tissue that could be contributing to symptoms. And before adding more medicine, you want to kind of have a better sense as to what's going on. If the upper endoscopy is normal, that's when they've looked at the tissue. That's when you would, and symptoms continue, then you'd think about motility testing, looking at the function in the esophagus and in the stomach. And if the function is abnormal in either of those two places and symptoms are continuing, it's possible that the person may benefit from prokinetic agents or promotility agents in addition to their acid reflux medicine to help their symptoms. And there are a variety of medicines that we use, as you can see in the yellow sidebar, that can benefit patients with decreased appetite and weight loss, for example, that want to gain weight and have a low appetite, and have dysfunction in the stomach, or if they have difficulty sleeping or early fullness. There are certain medicines that we can use to help those symptoms in addition to the gastrointestinal symptoms. So many patients ask me, well, if my symptoms are mild, does it really matter? Or do I need to take medicine for acid reflux? And really the answer is yes. And the reason for that is that there are many complications that can occur in the longer term if acid continues to invade the esophagus. And again, as I mentioned before, the stomach has a protective lining that allows acid to live there without causing trouble most of the time, but the esophagus does not have that protection. And so the acid can actually digest some of the tissue in the esophagus and cause bleeding, ulcerations. It can cause, over time, that inflammation can lead to scar tissue, like you can see the narrowing of the esophagus here. which can obviously cause trouble, as food tries to pass. It can lead to precancerous lesions and breakdown in the integrity of the esophagus. Shown more recently that microaspiration of the acid can actually have an impact on lung function and interstitial lung disease and scleroderma. And this is still an area under active investigation, but these are really good reasons why it's important to take your medicines and do your best to comply with lifestyle modification. So in terms of the lower gastrointestinal tract, there are many areas that can be affected that can lead to constipation, diarrhea, and incontinence, as I mentioned before. One of those is the colon, where you can have slow transit of stool as it's leaving the body. And if that gets backed up, you can get a lot of distension and bloating. And the backup of stool can even lead to bacterial overgrowth in the small bowel. And so that's something that can complicate the clinical situation when you're trying to figure out why your small bowel is having trouble working. So that's one of the potential causes of SIBO. The second is the small bowel. So the small bowel itself can have slow transit, and that in and of itself, even in the absence of slow colonic transit, can lead to small intestinal bacterial overgrowth and symptoms of bloating and distension, and oftentimes diarrhea. And this can be very debilitating for patients. And the anorectum, again, as we mentioned before, can be involved. You can have trouble with muscle coordination and then loss of sensation and trouble with the nerve muscle interactions that can lead to either symptoms of incontinence or symptoms of constipation. And so you can see here that it's really important to understand what you're treating. If the symptoms are refractory to standard of care medications that are low risk, before you amplify therapy, it's good to have a sense as to the exact problems that are ongoing in a certain individual. So treatment for lower GI disease can be complicated. As you heard, there are multiple causes of small intestinal bacterial overgrowth, multiple areas that can be affected by slow motility, and multiple areas that can be affected, obviously, by the abnormal nerve and muscle coordination. And so some of the things that we think about once we have a sense as to what's going on is the promotility agents. So in the small bowel, the promotility agents that we use don't completely overlap with the medicines that we use in the large bowel. And so that's why I like to try to distinguish between and identify the region or regions that are affected, because it could affect the drugs that I choose. So for example, octreotide is a promotility agent that has been around for a long time, and it's good in the small bowel, but it doesn't really work in the colon. Then these other medications can be helpful, and then cyclic antibiotics can be very helpful for patients with small intestinal bacterial overgrowth. Now, there are a lot of questions around antibiotics in the context of the microbiome and how much benefit versus harm that they do. And that's still under a very active area of investigation. But for now, they're helpful in managing symptoms in patients where other things haven't worked. In terms of the large bowel, these medications can all be helpful. Some of them enhance motility. Some of them soften the stool through the active secretion of water into the colon. And for the anorectum, there are many things that can help with fecal incontinence, but usually the first two things that we recommend are in eating foods that can bulk up stool, like oatmeal, so because you're less likely to have fecal incontinence, for example, if you don't have diarrhea. And the second thing is biofeedback and physical therapy. If you can find a good pelvic physical therapist, that's the first line usually in dealing with anorectal dysfunction in scleroderma. So we've talked a lot about motility. The next thing that's important to think about are the 10 trillion bacteria that live in your digestive system. And for a long time, we kind of ignored them as a world, and they've come into the spotlight in the last several years and are again, a major focus of investigation in gastroenterology and related diseases. And while we have a very limited understanding of what they mean in scleroderma, there is some data to support the idea that in scleroderma, some patients have lower amounts of good bacteria and higher amounts of bad bacteria. And this imbalance can lead to worsening symptoms. And we're currently doing a study right now with Dr. Volkman at UCLA, looking at the interaction between transit, the composition of the microbiome, and patient's symptoms. And so hopefully we'll have some more answers in the coming years about this. I get a lot of questions about diet and nutrition in scleroderma. There really are no specific recommendations on a particular diet that all patients should follow. We tend to recommend that patients avoid foods that aggravate their symptoms. And as you can see, based on the heterogeneity or wide differences across individual patients with gastrointestinal complications, you can see why there might not be just one recommendation that would work. Some patients like to try the FODMAP diet. There's limited data that may help, but it's very limited data, so we don't recommend that broadly. And there is a study that showed that patients with scleroderma can have a higher likelihood of having fructose malabsorption. And so sometimes we'll do a trial of fructose elimination or a breath test looking at fructose to see if patients may have symptom improvement with this dietary adjustment. Now, there are several areas that we have talked about. I gave you a lot of information today, and sometimes it can seem overwhelming, but I hope that you have a better understanding of what's going on in your body, the different things that we can do to help. And then now I'd like to show you what's some of the things that are on the horizon that are really exciting that we hope to accomplish in the coming years that will ultimately, hopefully, improve your quality of life and improve the way that we can treat patients with scleroderma. So some of the main research questions that we have are when to treat, who to treat, and with what. So one of our goals is to identify biomarkers to support clinical risk stratification and outcome prediction. These are big goals here, but what we break it down as is we basically take a blood sample from our patients. And this work has been funded by the SRF. They've been incredibly supportive of this work. So we take blood from patients, we screen their blood for antibodies that are new and haven't been found. They're basically little markers in the blood. And we're hoping to determine whether these antibodies can tell us more about the types of complications that patients will experience, whether or not their gastrointestinal disease will stay stable throughout their disease course, or whether or not it will progress. And then in the longer term, we're hoping that, using these biomarkers, we may have a better sense as to what treatments would need to be considered at some point during their disease course. Now, we're also working on defining the relationship between abnormal transit and the bacterial composition in stool. As I mentioned before, we're looking to see how both of these things impact symptoms in patients and how the bacteria impact motility and motility impacts bacteria. So hopefully by gaining a better understanding of these things, of these interactions, we can ultimately improve our approach to therapy. And so finally, we're trying to identify the cellular targets of the autoimmune response in scleroderma. And we are doing that by taking one-dimensional to a two-dimensional view of the enteric nervous system so that we can better understand where the problems are. If you have a two-dimensional image of a bus that's broken down and not working, and you only look at this picture like we would here of the nerves in the gut, you wouldn't understand that it's not working because the wheel is off. So we hope to show a three-dimensional image here of the gut to see exactly where the problems are. So on that note, patients can get involved by reaching out to the SRF and asking what studies are ongoing in this area. And by reaching out to our scleroderma center at Hopkins. So in summary, the cause of scleroderma GI disease is complex. We're working to understand nuances so that we can target therapies appropriately for patients. And we are looking at novel therapies, combination therapies, and understanding the etiology of this disease in the future with an eye towards bringing our current care to the next level. And just to reiterate, we're at a really exciting time in scleroderma research where your involvement can make a really big difference. And we hope that you continue to stay engaged with this community. It's a great community where we're making strides each day. So I'd like to thank the SRF for inviting me to speak today. It's a really special organization, and they've supported me since I was just out of fellowship. And you can see Deanne and Luke listed here, and they're really committed to understanding scleroderma and couldn't be more focused on finding a cure and improving the lives of patients. And they fund investigators like me. And I can't tell you how much that's meant to the development of my career and the progress in the work that I've made towards understanding GI complications. I'd also like to thank the Johns Hopkins group, both in scleroderma and gastroenterology, and our patients, of course. And then I also remember Bob Saget, who I got to meet one time, but he was one of the kindest, most approachable people. And he introduced me when I was a baby doctor at Cool Comedy, which is an event the SRF hosts in New York. And he was such an advocate for scleroderma, and we will all miss him greatly. So thank you for everyone for attending, and I'm delighted you took the time and hope that you will again stay involved, and feel free to ask any questions.
That was just a fantastic overview and tons of detail, Zsuzsanna. Thank you so much. I will just, we are running just over a little bit already. So I just wanted to note for all those folks who are listening that Dr. McMahan has already agreed to come back and expand on this webinar and take on some of these other issues that we didn't have a chance to cover in all its appropriate detail. So please look forward to that coming. And I'd only just take just one more second and really emphasize one of the points that was made here in the closing remarks, that patients can call either the Scleroderma Center at Hopkins, or they can reach out to the Scleroderma Research Foundation or check us out on the website if they're interested to participate in research. It's we really need your contributions and your commitment in order to make the kind of progress that you've already seen and to continue to make progress in the future. So with that, there have been a number of excellent questions. We're going to try to get to at least a few of them. Maybe just at sort of a fundamental level, just that I'm sure it's on a lot of patients' minds. You mentioned tomato sauce. Are there other foods that you should be sort of on the watch out list for patients as they try to navigate their reflux? Obviously, a very common complication for most of our patients.
Absolutely, Luke. That's such a great question. Other foods that tend to have a lot of acid content include like fruits, oranges, lemonade, orange juice, those types of foods. Other foods with red sauce like pizza. So not only spaghetti, coffee can unfortunately aggravate symptoms. Chocolate, all the good stuff. So, many patients can tolerate small doses of these things, and there is a balance in quality of life. But it's best to minimize ingestion of these types of foods so to protect your body.
That's great. Maybe on the other side, away from certain things to avoid, I know, and we get a lot of questions at the SRF about things that patients should ingest, and obviously that leads to a conversation about probiotics. You talked a little bit about the gut microbiome, and obviously there's been a tremendous resurgence of research on that dimension. What do you recommend for patients who are interested to consider probiotics, and what do you think is a thoughtful way to approach that for patients as they're trying to self-medicate, if you will?
Right. So as I mentioned, probiotics don't have a lot of data behind them, and it's still an evolving field. But that being said, there is some data in scleroderma that probiotics like Align and Culturelle may help some patients with distension and bloating. So those are two of them that you could try. With any of these trials, I'd recommend a shorter time period, so maybe a few weeks to a month. And if it's not working in that time frame, then it's something that you could probably discontinue. But there are a handful of patients that are under my care that have really benefited.
Great. One of the topics that I find really promising, and I know you're in the middle of this personally, and Hopkins more broadly, but to talk a little bit about trajectory modeling and whether there are signs and symptoms that patients might want to pay particular attention to, or signs and symptoms that you're particularly focused on that seem to indicate modification of trajectory. And perhaps you can also talk about different subtypes, particularly say limited and diffuse disease, as you in your comments about trajectories.
Yeah, sure. So we've done a couple of smaller studies looking at more severe GI disease, meaning that patients are on total parenteral nutrition or pseudo-obstruction, and looking for risk factors in those groups. And in those groups, some of the risk factors for more progressive disease were actually being male, being non-white. Having diffuse disease was a risk factor in some of those cases, and having muscle involvement, skeletal muscle involvement, which was somewhat surprising to us. And so, we're still trying to tease out much more what each of because then the next question is really, who are those patients? Because not every patient with muscle involvement gets severe GI disease. And we really want to know and understand who those people are. So right now we're taking, this is a new study that we're just about to start. We're taking the 4,000 people in the Johns Hopkins database and trying to understand which ones stayed stable over time and didn't get worse, which ones declined rapidly and stayed very sick from their GI complications, and those who declined slowly, and those who declined but then improved. And we think that in this large cohort of patients, we can identify some specific risk factors, like Luke had asked about, that can distinguish between groups. Now, we did recently publish a paper showing that in patients with slow colonic transit, that they were enriched, and it didn't ultimately end up being significant in our model, but there was a strong association between anti-centromere antibodies, which are usually seen in limited scleroderma, and slow colonic transit. And so we think that the colon, for some reason, is disproportionately affected in this group of patients. And so we're trying to understand the biology behind that right now, and some exciting translational work that we're doing with gastroenterology.
Great, thank you. Well, I think, we've now hit the 45-minute past the hour mark. I do want to be respectful of your time. You've been very generous with us, and just maybe move to sort of our wrap-up comments. Again, I want to thank Dr. McMahan for a really fantastic overview. It's a complicated topic, and I think she really brought out many of the critical issues. And of course, we'll have to circle back and cover the few that we weren't able to cover. If you want to learn more about the Scleroderma Research Foundation, please visit us at srfcure.org or call us at 800-441-CURE. We're always there for our patients, and we will continue to fight for you and deliver on the mission. So again, thank you, Dr. McMahan. Pleasure for everyone for joining us. Bye-bye for today.
Thanks again.